Who is that person behind you? Who is the person behind you? Who is the other person? Prince, you know they hear word. Give me that phone then.
Mute your microphone before talking.
Ini diunda. Ihe kwesịrị na ihe ha
What's going on? Have we started?
Sure. To access your camera from device. Very open. These are the What did people are not? Everybody is on mute. That means they are the ones that mute us. They're not here. They're not here.
Good morning, everyone. Welcome to this week's episode of the series workshop. Today is a continuation of the last week of cardiopulmonary physiotherapy, and we are going to have the radiological principles in cardiorespiratory physiotherapy. And here with us is Dr. James Jesni, and good morning, sir. Welcome for another day.
Good morning, my brother.
Good morning,
I'm glad
sir.
to be with us.
Good morning. Good morning, everyone.
I think it is 10 a.m. now. Sir, if you are ready, we can start.
Okay. Yes, I'm fully set. Thank you very much, Dr. Jibrin. We give glory to the Almighty God who has spared the life of each and every one of us to be part of this program today again. It's been exactly 1 week when we last met virtually. We are grateful unto him. And I want to once again appreciate the organizers of this special program for the privilege accorded me to be with us today again to share knowledge with my beloved colleagues from north and south, east and west of our beloved country, Nigeria. And I want to welcome each and every one of us that are online already, as well as those that will be joining us. I believe, God, that it will be a refreshing time for each and every one of us. Like we have been told, it is more or less a continuation of what we had last week, but this time around, we want to actually see how we can enhance our diagnostic skill our treatment planning scheme, and how we can actually monitor and modify, being supported by some technological tools. So, like we've been told, we are looking at radiological principles. We know that in what we do, a good number of times we'll, consult some imaging results. And that's the focus today. First of all, let me share my screen. Can we see my screen now?
Yes, sir.
Okay, thank you very much. Okay, so we are on another edition of the CPD series. And once again, you are most welcome. I tried to tag the presentation, in terms of summary, radiological investigations in cardiorespiratory disorders. What investigations do we carry out? Which ones are we interested in? What can we get from them? And how can the findings of these investigations impact on our practice? So first of all, the objectives that we are trying to accomplish through the various presentations we'll be having today are listed on this slide. We desire that at the end of the presentations, participants shall be able to understand the role of radiology in cardiorespiratory care, identify appropriate imaging modalities, interpret radiological findings, integrate radiological information into physiotherapy practice, collaborate effectively with radiologists and other members of the healthcare teams, review case studies, and be motivated sufficiently to stay updated on advances in radiological techniques, because day in, day out, technology continues to advance, and we must advance as technology advances. Again, this is showing a plan of what we intend to cover. But eventually, on my preparation, I realized that the thing is too loaded to be completed within the time frame we have. So right from the beginning, let me crave our indulgence that our major focus is actually how we as physiotherapists utilize radiological findings. And that's the one that is the 6th presentation. So as I continue to follow sequentially, at a particular point in time, when I see that maybe time is a bit spent, especially once it is getting to, or once we go on break and we come back, no matter where we have reached on the other topics, we will jump to physiotherapy utilization of radiological findings. Because apart from presentation, I will want us to actually tackle some cases, case studies, and do case-based learning together. So I want to crave your indulgence that as we start now, whichever lecture we reach and we go on break, when we come back from break, we just go into utilization of radiological findings. I believe that in the course of doing that, whatever topic we have jumped, there will be some reference to it, an allusion to the content when we handle how we utilize the findings. Thank you very much for your understanding. So without much further ado, the first presentation I have titled Introduction to Radiological Investigation in Cardiorespiratory Care, in order to lay the foundation for all that we have to say. And I've broken this particular presentation into 3 components: introduction, then an overview of imaging modalities. Of course, even under that overview, I have only touched the very common ones, about 6 or 7 common ones. We have quite a number of others that are not mentioned there, but in the course of my speaking, I will mention them, but we won't delve into them because they are not very common, especially around our climate here. And then the third component is importance of imaging in cardiorespiratory physiotherapy. That's to whet our appetite to go along in the course of the seminar, realizing how important the subject matter we are on is to us as physiotherapists who are interested in cardiorespiratory care. So, starting from the first part, which is the introduction, we say that in cardiovascular and respiratory systems, we use diagnostic testing to evaluate anatomical or physiological function of the various organs that are related to the cardiorespiratory function. And then we are talking about the heart, we are talking about the blood vessels, we are talking about the lungs, we are talking about even surrounding structures of these 2 major organs. In other words, we are looking at the pericardium, we are looking at the pleura, we are looking at the mediastinum, we are looking at the pleural space, we are looking at adjacent nodes, and the various vessels that, either go into them or come out of them. So we use diagnostic testing. And in this diagnosis, radiology plays a very crucial role. And that's why we are focusing on it today. Why should we be interested? Because a good number of the things we have to handle, the pathology or the pathophysiology, are deeply embedded or located within the body. And obviously, we can't see them with our physical eyes. In our 4 steps of physical diagnosis, observation, palpation, percussion, auscultation, we are not even able to reach these structures and tissues. And yet, it is deep down there that the problem lies. So how then can we really see and accurately identify what has gone wrong? That's where these techniques have become so valuable to us, because they provide some insight into the structure of these vital organs, insight into their function that we cannot otherwise lay hold on, and therefore those information that we can derive from them can aid us in detecting various cardiorespiratory conditions, characterize them in terms of describing what is actually going on, and then we can monitor the trend, whether left untreated, it deteriorates or it stabilizes. And if we actually intervene with our intervention, whether there is any improvement or there is deterioration in spite of the intervention. So these are the things that make imaging techniques to be so valuable to us as cardiorespiratory physiotherapists. And apart from, being useful in the cardiovascular realm, it is also useful in the respiratory realm. And we know that these two systems, they actually, work symbiotically. And that's why in the specialty, we refer to it cardiopulmonary. So, we say imaging also plays an essential role in evaluating the lungs in terms of structure, in terms of function. And the imaging of the chest can actually assist us in establishing a diagnosis. It can assist us in monitoring the severity of any disease entity and as well actually screen for them. Now, when we desire a radiologic investigation, what's our purpose? What are we looking forward to? It is that we may be assisted in the diagnosis of the condition that is before us, that we may be assisted in the management, and that we may be assisted in the planning of the line of intervention. These are the purposes for radiologic investigation. Now, in carrying out this investigation, radiology has a great arsenal of modalities, of techniques, of equipment, to carry this out. So in this second part of the introductory presentation, I want to cover an overview of imaging modalities. And like I've mentioned earlier on, it is not altogether exhaustive, but representative. Now, the old school, the old reliable, is the chest X-ray. I mean, popular everywhere, readily available. Compared to most other techniques, the cheapest. Now, under the overview, there are standard aspects of the modality I will talk about. The principle that undergirds its work, what will require its use, and its relative advantage over some of the other imaging modalities, and whatever may be its own weakness or limitation. So talking about the chest X-ray, this modality uses X-rays, which is a component of the electromagnetic spectrum, to create images of the thoracic cavity. And so it creates images of various structures and organs that we have within that thoracic cavity. And the kind of image it creates depends on the so-called either radio opacity or radiolucency of the tissue. And these attributes vary from one tissue to another based on their densities. Now, talking about the indication for chest X-ray, wherever, we are trying to make an initial assessment of respiratory symptom, then we will need this investigation to support our assessment. Or when we are evaluating, for cardiac size or a particular lung pathology, or even fracture within the thoracic cage, then chest X-ray becomes needed. The advantages of this particular imaging modality include the fact that it can quickly be obtained. X-rays are, images that you can collect within 10, 15 minutes of having, taken the X-ray. It is widely available. I mean, in any particular city, you even find private X-ray centers and things like that. And you even have the mobile appliances. Now, the third advantage is that it is cost effective. It is not beyond the pocket of so many. When people are given the card to go for MRI or to go for CT scan, I'm sure you are familiar with how people will shout and yell and say, because of the price and the economy of the nation. But when people receive prescription to go for an X-ray investigation, it's not often attended with such sigh as when you talk about MRI or CT scan. Now, as popular as it is, as readily available as it is, it has some limitations. In terms of the kind of detail that it can provide, it is limited. There are modalities that can provide us with greater details than the X-ray has to offer. And when it comes to the soft tissues, I said that the radiopacity or radiolucency is dependent upon the density of the various tissues. When you look at the soft tissues around the thoracic cage and whatever, you discover that the densities are not too far from each other in terms of value. So the X-ray is not able to sufficiently contrast the soft tissues as some other modalities will actually, because they are more sensitive in terms of differentiating and contrasting the densities. So these are the limitations of the X-ray as an imaging modality. The next one is the computed tomography or CT scan. This particular modality, in terms of the principle or the mechanism of working, it combines X-rays with computer technology to produce cross-sectional images. X-ray will just produce a unidirectional image. But with computerization, the CT can produce even cross-section of tissues. Now, it is indicated when we desire a more detailed evaluation of the lung parenchyma than what the X-ray has to offer. For example, if there's pulmonary embolism in any of the pulmonary arteries, The X-ray is not sensitive to differentiate. Or if there's a tumor, the tumor is a soft tissue, the lung parenchyma itself is a soft tissue, and so the X-ray will not be able to differentiate. But with the CT, it is capable of differentiating them. Or when we are interested in assessing the mediastinal structures or, or the pleura, we are able to get this with CT. And the added advantage is that there is even a version of it that is referred to as the high resolution CT. And this is particularly useful for interstitial lung diseases because of the high resolution. The advantages is that, it has a high spatial resolution, and then it is able to detect small lesions. Of course, it also has some limitations. High radioactive exposure. And then it is more expensive and it is less available. Then we have the MRI, the magnetic resonance imaging. The magnetic resonance imaging modality, unlike X-ray and the CT that use radiations, MRI does not use radiation. Rather, it is dependent upon the hydrogen ions in the water molecule in the various tissues of the body. And so it uses a strong magnetic field and radio wave to create detailed images. And it is indicated, especially, in investigating the heart, for detailed assessment of the cardiac structures, the viability of the myocardium, presence or absence of congenital heart diseases, as well as evaluating some complex chest wall issues. In terms of advantages, it has excellent soft tissue contrast. And since it is not using any radiation, there's no ionizing radiation. So the risk of ionizing radiation exposure is absent in terms of MRI. So that in individuals that are sensitive to ionizing radiation, MRI is the alternative to CT. But it has some limitations. It has longer scanning time. The process takes longer to capture the images that are needed than you have for CT or for X-ray, which is even extremely very short. It is expensive. And when some patients have certain types of implants, it may not be suitable. Just like in physiotherapy, when we talk about the usage of shortwave diathermy, and we say that when there is a metal implant, then it is a contraindication. So we also have such for MRI. Another imaging modality, is the echocardiograph. So the procedure is echocardiography. Here, ultrasound waves are used to produce images of the heart. And its use is indicated when we want to assess cardiac function, when we are interested in checking valvular diseases when we are interested in checking for pericardial effusion, and then when there is a ischemic heart disease and we want to evaluate, stress echocardiography can be very, very helpful in such a situation. In terms of advantages, the advantage that echocardiography has over the others is that you can, observe the image right at the point where you are trying to capture it. You can view it on a monitoring screen. So it has real-time imaging. X-ray does not have that. You use the X-ray machine to snap the image, then you have to take the film for development, washing, drying, and everything before you can now view the X-ray film. The CT, you have to do it on the machine and everything, and it is after that you can get it out of the machine. But for echocardiography, you can view it right at the time that you are doing. So we talk about real-time imaging. And then it is non-invasive. And since it also does not use any ionizing radiation, the risk of a radiation exposure is absent. However, it is limited by the operator dependency, as well as a patient's body attributes. Just like when we talk about some modalities in physiotherapy, and we say that there are challenges using them when you have an obese patient. So likewise, echocardiography has such limitation. Now, another modality is the nuclear medicine imaging. And in nuclear medicine imaging, little amounts of radioactive material is used to assess the function of, certain organs and to assess some structural integrity. So radioactive materials are actually introduced into the body. And such use is required or indicated when we want to look at myocardial perfusion, to see if there is any problem with the coronary arteries. It is also indicated when we want to do a ventilation perfusion scan, in other words, to see whether the exchange of gases and the availability of blood in the across the respiratory membrane is sufficient or not. Then it has the advantage, it could give us functional assessment of organs, and not just structural assessment, but it can provide us with functional information, performance. Then it is able to detect diseases early. Some of the other modalities, they are not able to pick the disease until the disease is full-blown. But for nuclear medicine imaging, it is capable of detecting the disease at a very early stage. And that has a very great medical advantage in that we can immediately nip things at the bud. Take, for example, even though that's not really cardiorespiratory now, I'm sure we are aware that for women, they ask them to do regular breast examination, because a good number of times when they come up with a breast cancer, cancer, it is often devastating because most of the time it is not detected in time, on time. It's not detected sufficiently early enough to have been able to mitigate the adverse effects and reduce the impact on the quality of life of the sufferer. But with nuclear medicine imaging, such challenges can be averted because you can pick it early and you can begin your intervention in good time and limit the extent of damage that the cancer cell can cause. Now, another imaging modality is the positron emission tomography, the PET or the PET scan. The PET works on the principle whereby, apart from the fact that it has the computerized tomography, it is supported with some nuclear or radiating materials to assess metabolic activity. So it's like a combination of nuclear medicine imaging and CT imaging. And just like it is often said that two are better than one. So you can see the strength or the relative advantage that this particular modality is going to have because it is combining two potentials in its own function. So it is indicated when we want to evaluate, the development or the stage of cancer, in cancer staging, the viability of the cardiac musculature and its function. It is indicated, for the identification of infectious or inflammatory processes. And the advantage is that it is highly sensitive in detecting malignancies. So it is also capable of nipping things at the bud. But the limitation is that it is very expensive. Because it combines nuclear imaging with CT, the radiation exposure is also a risk. And then, compared to CT or MRI, it has a lower spatial resolution. Even though it can pick things earlier, it is not capable of differentiating as accurately as CT and MRI would differentiate. Now, before I go on, I said I was going to mention some of the other modalities that have not handled here. We have the stress duplex ultrasound, the electrocardiography. We have the electron beam computerized tomography, which is the EBCT. We have the multi-detector or multi-slice spiral CT, which is the MDCT. We have the LT. We have the MSCT. We have the gallium and other radionuclide scans, apart from CT scan. We have, apart from the MRI, we also have the cardiac magnetic resonance. That's also an imaging modality. We have the cine MRI, which is like, a cinematographic version of the MRI. So we have the radionuclide angiography, And then we have the single photon emission computer tomography. So, but all these other ones that I've mentioned, they are not as common. We also have the thallium scan, but they are not as common as the others that have gone into. So, giving us a kind of comparative overview now, a major risk in all this is radiation exposure. It is lowest for echocardiography and MRI because they do not use radiation, either magnetic field or sound wave. And it is highest for computerized tomography, nuclear medicine, and positron emission tomography, PET. So when we therefore want to select, we weigh this risk, and then we can sway between the two ends, depending on what becomes the utmost priority in our consideration. In terms of cost, the modality with the lowest cost is the chest X-ray. And the highest is the MRI and the PET. They are very expensive. In terms of availability, the most widely available is the chest X-ray. And the least available is the PET. So, now, integration, in clinical practice as physiotherapists, especially in the cardiopulmonary specialty, the choice of imaging modality should be based on certain factors. The clinical indication. So we are looking for what exactly are we trying to get and what is capable of providing us with the information that we need. Then availability. So if we now have 2 or 3 possible modalities that could give us the information we want, which one is more available? And of course, if it is more available, it's likely to be cheaper. So it will also address the issue of cost. And we must be economical, in our practice. The next one is the patient safety. So which one has a lower risk radiation-wise? And which one will give us the specific diagnostic information that is required? So these are the factors that we base the choice of modality on. Like I said, technology is advancing daily. And so even the future of imaging, we can't see it for now because things are daily evolving. So diagnostic capabilities in cardiorespiratory care will continue to be enhanced as we have imaging technology advance, especially now that scientists are going into hybrid imaging modalities. When we talk about hybrid imaging modality, we saw where CT, computerized tomography, is now being combined with nuclear medicine. So the scientists are now developing hybrid modalities that can combine the attribute of 2 different ones in order to give us something better. And in terms of computerization, we know the wonders that artificial intelligence is beginning to bring to the table now. So as artificial intelligence is even introduced or integrated into imaging studies, we just cannot tell what the diagnostic capabilities in cardiorespiratory care will be tomorrow. And that is therefore a challenge to each and every one of us to keep ourselves up to date. And I want to appreciate those of us that are on this training, because that is the spirit that has made us to carve out this time. Most of us have other things that we could be engaged in doing today, but we have decided that we want to sharpen our knowledge, we want to sharpen our skill, we want to be up to date. And that's why we have made out this time. And I know it is also not coming to us free of charge. So for us to pick the money that we could have used for some other luxuries or comfort and pay it for a continuing professional development program, it talks about the spirit we have in terms of advancing with practice. And I believe that it will manifest in our practice for the betterment of our patients. Now, finally, in this introductory presentation, we want to very quickly look at the importance of imaging in cardiorespiratory physiotherapy. I'll just mention it briefly here, because later on, I'm going to expand the more when it comes to the specific usage of imaging studies by physiotherapists. Number one, imaging serves as a critical tool, in assessing and managing patients with cardiorespiratory conditions. It offers insights that inform diagnosis. It offers insights that inform our treatment planning. It offers insights that inform our outcome evaluation. And so in cardiorespiratory physiotherapy, imaging is indispensable. And, it influences every stage of our practice, from diagnosis to the point of outcome evaluation. And when it comes to the issue of the diagnostic stage, it enables us to detect pathology early enough. It enables us to differentiate conditions one from another. It enables us to identify contraindications. When it comes to the aspect of treatment planning, imaging studies provide us with, insight that assist us in informed decision-making. We are not just making decisions offhand there. The decisions we make are based on information that we have derived from these studies. So our decision become informed, decisions. It assists us in tailoring our intervention, because there are some findings that the imaging studies will provide to us that will make us not to do what we probably would have intended to do based on the symptom that we observe. In that, for example, if a patient, this is not cardiorespiratory now, let me just use that, has ligamentous tear, compared to when there is strain or sprain. the symptom that the patient will present will appear similar: pain, tenderness, warmth. By virtue of the fact that we cannot see the inside, we can only feel the warmth. We can get feedback from the patient about the pain. We can observe the swelling. We may want to engage in some form of mobilization or exercises. But by the time we are able to do an MRI that is capable of giving us information about the tissue and that shows us that this is not sprain, but an actual tear, then that which we will have done if it was just sprain or strain, we are no longer able to continue with such a plan. We then modify the plan to suit what the MRI has shown us. So it helps us in tailoring our intervention. Of course, it also assists us in monitoring treatment progress. For example, there are some respiratory challenges that when we are setting our goals, the goal may be that the X-ray finding in Mr. X shall be fully resolved after 15 treatment sessions, stating the goal as a SMART goal. So it means that it is the repeated imaging study that will give us the picture that something has been fully resolved. So imaging studies can assist us in monitoring our treatment progress. Of course, it can also assist us in our outcome evaluation to measure the effectiveness of our treatment. If you compare the result at different points, you can see the rate of progress. And the rate of progress in the patient is a reflection of the effectiveness of our intervention. It can also be useful for long-term monitoring because you can keep on repeating this imaging study even long after the patient might have been discharged as a kind of follow-up. And of course, it is also useful for patient education and empowerment because, okay, take for example, the X-ray film, the MRI films and things like that. By the time you show it to the patient and you use it to explain to the patient what has gone wrong and the basis of what you are doing, the patient is better informed about his own condition. If he has to do some lifestyle modification as part of the treatment strategy, having seen that, which has provided a kind of visual feedback for him, the motivation to adhere, to the treatment plan is better than if he is vague about what is going wrong. And, it can also assist in the treatment intervention as things change and you continue to show him, the patient himself is empowered to become part of his own treatment. So that is the end of the introductory presentation before we now fire into the other presentations. I wouldn't know if we have any questions so far, any comments so far. comments, questions before we move on to the next presentation? What's the next presentation?
I think it's clear, sir. Thank you, sir. Let's fire on.
Okay, thank you very much. So we move on to the second presentation. Okay, let me stop sharing this. Is it pausing it? Why is it saying screen sharing is paused? What's happening? Sorry, while I'm battling with my screen share, I can see Chuks Iwuchukwu raising the hand. Is it that he has a comment or is it that he forgot to lower it? I don't know why he's telling me that my screen sharing is paused. Sorry, I'm having a little challenge with screen sharing here. He's saying my screen sharing is paused. I wouldn't know if there's anybody online who knows the solution to such an issue. Yes. Okay, let me try that option. Thank you. Let me try the option. Can't see any resume here. Okay. I think what I will do is let me exit and re-enter and see if that will solve the problem. Just a minute. Are we able to see my screen now? Hello? Are we able to see my screen now?
Yes, sir.
Yes, sir.
Uh-huh.
Yes, sir.
Okay,
Yes, sir.
thank you. Yeah. So it's this restarting the Microsoft that worked. Thank you very much for that counsel.
Yes, sir.
Yeah. So okay, so the second presentation is on the popular chest X-ray. And we want to look at it, its use, and then the interpretation. For us to be able to effectively use this imaging modality and the findings of its investigation, there are certain things that are fundamental and foundational. And one of such is the understanding of the anatomy in X-rays, especially when we talk about the chest X-ray. Number one, the lung fields. Being able to recognize the right and the left lung fields. Being able to identify the lobes. Familiarity with the surface anatomy of those lobes. And therefore, when we spot a lesion in any portion of the field, to be able to specifically talk about which lobe that problem is located. To be able to understand and, the mediastinum and identify the structures within that space, such as the heart, the aorta, and the trachea. The diaphragm. And then, because of the dissimilarity, in other words, difference in the shape of the dome of the diaphragm on the two sides, being able to differentiate the right and the left diaphragmatic domes. Then the ribs, the direction in which they run. The clavicles, because of the landmark it represents and the reference that it is to various points when we want to describe. The alignment of these various bony structures, they are very, very important. And then we are also required to understand the positioning in chest X-ray. When we talk about anteroposterior and posterior-anterior view, a good number of times, the views of the chest X-ray that are with us is the posterior-anterior view. But a good number of times, because the X-rays for other parts of the body are often anteroposterior view, and so when people make requests, they say AP and lateral, anteroposterior and lateral views and whatever. A good number of times too, for the chest X-ray, when we receive it, we mistakenly refer to it as AP view. Most chest X-ray are PA view and not AP view. AP and PA is descriptive of the direction through which the X-ray beam traveled to capture that image. You will recollect with me and agree with me that when the person to take a chest X-ray gets into the X-ray room, he stands holding his chest against the film. And it is from the back that the operator, who is actually located in another room, looking through the window, presses the machine, and the machine takes the film. So the X-ray beam comes from behind the patient to the X-ray film. So that is a posterior anterior view and not an anterior posterior view. However, in some instances, there may be anterior posterior view, especially where if the patient is bedridden. And in that instance, the machine is from above and the patient is lying supine. And the film is underneath the surface on which the patient is lying. So that is when we have an AP view. So we said the anterior posterior view is the view that is taken when the X-ray beam passes from front to back. And it's often for bedridden patients. But the standard view that is most common is the posterior anterior view, which is taken with the X-ray beam passing from back to front. And the advantage of this is that it provides a clearer image with less magnification of the heart. The anterior posterior view magnifies the heart, and so the heart, in the image of the heart in the chest X-ray, appears to be larger than usual. Therefore, if, for example, we have two films of chest X-ray before us, and we look at one, we see the size, the area occupied by the heart, and one appears to be larger than the other. Before we run to the conclusion of cardiomegaly or ventricular hypertrophy or whatever inference we want to draw, we must immediately check what view is the film that I'm holding. If it is an anterior posterior view, that size is not strange. And we should not run to a wrong conclusion because of that. Now, we can also have the lateral view, which is used to assess the side of the chest. Now, something to note when we have this film in our hands, whether it is anterior posterior view or posterior anterior view, we must understand the differences in the heart size, just like I've explained. The heart size in the anterior posterior view is larger than the heart size in posterior anterior view. The diaphragm position, because of the inequality in its size and shape, we must understand the position as it will appear in AP view versus what will appear in the PA view. And then the scapular shadow. The posterior anterior view has less scapular shadow than the anterior posterior view. It is to ensure that usually when the person is standing against that film, he is asked to do like this. It is to shift the scapula away from the underlying lung field so that we can get a better picture of the lung field. That's why the patient is asked to do like that. I'm sure you will all recollect that. Whereas in the bedridden patient, for whom the anteroposterior is often used, they are not able to do that. Rather, because they are lying supine, they rest on the scapula, and so the scapula casts a shadow over the lung field. Now, the lateral view, the advantage is that there are some lesions that may not be visible in the anteroposterior or the posterior anterior view that the lateral view can bring out, because the X-ray is not three-dimensional. It's not a 3D film. Now, the common pathologies that are often investigated or that could be observed, with the chest X-ray are listed here. And the characteristic features in such films, when we talk about pneumonia, it's mainly characterized by consolidation. And depending on the type of pneumonia, we know we have, bronchopneumonia, we have lobar pneumonia, So the bronchopneumonia is much more widespread than the lobar pneumonia. So when it is lobar pneumonia, it is often localized to one lobe, and so is the consolidation is restricted to that place. Then another lesion that we can see during, when we are, with an X-ray investigation is pleural effusion. In pleural effusion, what happens is that the fluid in the pleural space between the parietal and the visceral pleura, is increased. And so the space is potentially larger. And then when the patient is standing erect, the fluid tends to settle down at the base of the lungs. And therefore, distends the pleura, at the base of the lungs, forming a kind of concavity that erases the costophrenic angle, in that area. So that is the characteristic feature of pleural effusion when we look at it in the chest X-ray. Then we can also check pneumothorax. Pneumothorax is simply talking about, accumulation or presence of air within some areas. And it makes the pleural line, to become very visible. And a good number of times, it becomes that visible because the lung in that area might have been compressed by the accumulated air, tending to collapse the lung in that place so that the pleural membrane cannot be obvious. Other conditions or pathologies include congestive heart failure, the enlarged heart size with the pulmonary edema that is seen, provides a kind of opacity in the lung field because the edema is fluid. And so it is air that is more translucent. So fluid will be opaque, hinder the passage of the X-ray. So it's going to appear opaque in that area. Now, COPD, where we have hyperinflation of the lungs due to air retention, especially if it is emphysema, Then, because of that, the vertical diameter of the thoracic cage will be increased. In fact, even the anteroposterior diameter is also increased so that it tends towards wanting to become equal to the lateral diameter. And so that is what gives rise to what we refer to as the barrel chest deformity, when the ratio of the anteroposterior diameter to the lateral diameter wants to become 1. Then we talk about the barrel chest deformity. And the expansion in the chest does not just occur anteroposteriorly, it also occurs vertically, whereby the dome of the diaphragm is depressed. So we can see a flattened diaphragm in such such a situation. Now, in interpreting, when we now have the film before us, a good number of times, when the X-ray film is coming to the physiotherapy department, it is accompanied by the radiologist report. And so sometimes, the physiotherapist does not bother himself trying to read the X-ray or to view the X-ray, to directly read it and interpret it, but rather simply relies and depends on the radiologist report. Good, because there must be division of labor. The radiologist is the expert in his own field. However, nothing stops the physiotherapist from actually having an idea and knowledge about this thing, so that you can, by yourself, also look at it and draw some inference. Because looking at that X-ray, there might be some things that you are interested in because you are a physiotherapist. And because of what you will be interested in addressing in that patient, the radiologist, being a medical doctor, is probably more interested in whether there is issue of inflammation, whether there is consolidation, whether there is infection, or whatever. Whereas you, as a physiotherapist, who is going to look at even the issue of ventilation and things like that, you might be interested in the shape and its relative sizes that the physician, who is a radiologist, by virtue of his own focus, has not mentioned inside that radiologist report. So if you are just totally dependent upon what the radiologist has provided, a lot of other information that the radiologist had probably been silent on will elude you. So it is actually good for the physiotherapist to also be able to pick the film, read it, and interpret it. And his interpretation can be supported, corroborated, confirmed by the radiologist report, especially in those areas where the radiologist report has actually mentioned those issues, because he is the expert in that field. Now, when you now therefore have to do it yourself, because there will be instances where, take for example, the patient went outside to take the X-ray, and because he needed to bring the X-ray for you quickly, the radiologist in the center where he has gone to take the film, is not on seat. Maybe the place is owned by a radiographer, and only is in business agreement with a radiologist to come at intervals to read and sign those films for him, and he wasn't around. And so they bring a film without a radiologist report. That should not handicap you from going ahead to study that X-ray and interpret. So how do we approach this process of interpretation? We start from the assessment of quality. You know, I'm sure you will have seen some X-ray film that are so blurred and not sharp, such that even the features that it is trying to show, they are not, clearly distinct. And you look at the film and say, what kind of film is this? So we assess the quality. You check for rotation. And then you check for inspiration. Usually, the X-ray is taken during inspiration, because that's when the lungs will be filled with air, and the X-ray will be able to pass easily and capture the various structures and be able to distinguish to some extent. Remember that the resolution power of X-ray is not as much as that of the CT scan, not to talk about the MRI. So if it is taken during expiration, when the lungs are actually empty of air, not to completely, because we remember that there is what we call the residual capacity, residual volume in the lung, So now, but as at that time, the structures will be crammed together, and so the X-ray will not contrast them very well. So you check whether, it was taken in inspiration, because that will give you a better film to read. And then you check the penetration in terms of the sharpness of the film. Then you now look at that film in a systematic way. You start from outside and you move inward. Looking at the thoracic cavity, what comes first that is showing on that film? Of course, the skin won't show on the film. The muscles won't show. But the bones, if it is the AP view, the ribs anteriorly. If it is a posterior anterior view, you will see the ribs posteriorly. And then you also see the anterior ribs, like a bit ahead of the posterior part of the ribs. So you progress from outside and you move inward. You look at the bone structures, you look at the soft tissues, and then you look at the organs that are located inside the lungs, the heart, the mediastinum, and so on and so forth. Now, you now correlate your finding from the film with the clinical symptoms that you have recorded during the physical assessment of the patient, in order to arrive at a harmonized picture of the patient's condition. Here we have a film of a normal chest X-ray, and the structures have been highlighted so that we could see their relative position and their alignment with other structures. Let me pick my tool. Let me just pick a pen. Yes. Can you see my mouse moving over the film?
Yes, sir.
Yes, sir.
Okay, thank you very much. Now, now you can see the esophagus coming down into the stomach, and then you can see the stomach. Now, you can see the clavicle. Right, left, right, left, because this is a posterior anterior view. No, sorry, it's this is antero posterior. So this is left, the stomach. The liver is to the right here. Now you can see the outline of the heart. You can see the tip of the heart that beats against the chest wall. I will refer to as the apex beat. Now, you can see the right lung, and you can see the lower lobe and the upper lobe. Remember that the right lung does not have the middle lobe. Now, you can see even in the shape of the heart, the wall, the thickness of the atria and then ventricle, and then you can see the interatrial and interventricular septum, and the cardiac musculature is highlighted in that blue. Then you can see also the trachea coming down, dividing into the right and left bronchi, which continues to bifurcate and divide. Now, you can see the various ribs, and therefore the intercostal spaces, which you can number in terms of second, third, fourth, fifth, sixth, and so on, intercostal spaces. So that when you are giving description, you can talk about the location of a feature that you are seeing relative to a rib, relative to the clavicle, because we talk about the last Sunday when we were looking at patient assessment, you recollect that we had those reference lines, anterior reference lines, posterior reference lines, and the lateral reference lines. So the memory of the location of those reference lines, mid-clavicular, mid-sternal, lateral, they are all important for describing location of whatever you see in this film. So now, having been familiar with this normal radiograph, when you now come across an abnormality, you are able to spot it easily. So let me drop my mouse now. Now, this is another radiograph. And I want us to look at it together. Now, this you can see all this consolidation. Look at the heart here. The location of the heart. It is diffuse. The edges of the heart on the left side is clear. You can see that line. But look towards the right. You discover that you cannot identify the edge of the heart towards the right side because of the consolidation. And because you cannot see that, and the heart usually relates with about the middle, the middle lobe. Yes, sorry, is the left that has lingular, the middle lobe. Now, that means that there is lobar pneumonia of the right middle lobe. Lobar pneumonia of the right middle lobe around here. Because you can see all the other parts, clear and radiolucent. So the consolidation talks about the inflammation. Now, this is another X-ray, another radiograph. Now, let's go back to the previous one. Look at this side. In spite of the inflammation or consolidation here, look at the costophrenic angle. Look at it here. You discover that the costophrenic angle is obscured because there is fluid accumulation that has caused the pleura in this place to sag and has become opaque, hindering the passage of the X-ray beam. And so we know that this patient has pleural effusion of the left side. Now, this is another radiograph. Let's look at the lungs on the left side. You can see it filling the thoracic cage, But when you look to the right side here, hey, what's up? Okay. They have helped us from the source of the film itself to map out the lateral border of the right lung. You can see the displacement from the wall of the thoracic cage to this, and that's indicated by these arrows, showing us that there is a medial shift. You know, the border of the lungs have been shifted towards the midline, separated from the wall of the thoracic cage, because there's air trapped in that place. And when there is air trapped, we want to, look at some other things, which obviously in this film now we cannot cross-check. And that's the issue of tamponade. Sometimes when there is either pleural effusion or when there is pneumothorax, when it is pneumothorax and it compresses, we talk about tension pneumothorax. When there is pleural effusion and it, presses and compresses on the heart, we talk about cardiac tamponade. In other words, it restricts the cardiac musculature from expanding. So, you could see the clear pleural line because the lung had shifted away from it. Now, what is the role of chest X-ray? The interpretation of it in our clinical decision-making process. In other words, in making our clinical decision about the patient, and when we are talking about our clinical decision making, it involves diagnosis, identification of problem, it involves treatment planning, it involves even the choice of intervention. It involves our goal setting. And therefore, it also affects our outcome measure. So these are all the areas that the interpretation of the chest X-ray is capable of influencing. So we said chest X-ray interpretation is a vital skill for cardiopulmonary physiotherapists, and it directly impacts the clinical decision-making and patient care. Now, when it is done, in good time and it is done correctly, it allows for early diagnosis. It allows for tailored treatment because you can, you can accurately say this is what is wrong. So your treatment can be tailored towards resolving the actual problem. It allows for effective monitoring because you know what you are monitoring. You know what you are looking for. It allows for patient safety. It allows for interdisciplinary collaboration because you can get information from other members of the healthcare team concerning it. You can forward information to others. You can discuss the patient's condition, intelligently with other members of healthcare that has one thing or the other to do in the care of that patient. And then it also allows for patient empowerment because you know what patient education that you can offer that patient, either in terms of lifestyle modification or even exercise program, especially if there is a home component that the patient needs to adhere to. When a cardiopulmonary physiotherapist has sharpened this skill it offers a lot of benefit on the long run. Early diagnosis and intervention. You can diagnose and you can intervene early. And you can identify the acute pathology. The skill guides your initial assessment. It helps you to tailor your treatment plan in line with the patient's actual problem. So you determine the appropriate intervention. And as you manage and the status of the patient changes through your repeated imaging studies to see how the initial issue is resolving, you can adjust, your line of management appropriately. You can monitor the progress and modify the treatment, because with your imaging study, you can evaluate the treatment effectiveness. And it will also guide your discharge decisions. It has actually been worrisome in the past. I want to believe that it is much better now. There have been studies in the past that reveal that in physiotherapy, we hardly discharge our patients. And the challenge is that with a good number of times, we have not made our practice to be outcome-based. Even where we try to make our practice to be outcome-based, we do not monitor and actually analyze the outcome that we collect, such that if you have an outcome measure that is supposed to be declining, maybe in terms of problem, and then it declines, and at a point in time, it begins to plateau, and the plateau is maintained for a certain protracted time, that's telling you that's the time to discharge the patient, because your continued management is not achieving any further improvement. But what we discover is that a good number of times, we don't discharge the patient, we keep on treating until the patient becomes tired and stops coming himself or herself. But when we use these imaging studies and the outcome and whatever an outcome, and we monitor appropriately, then it can guide our discharge decision to say, okay, you are okay, you can go home. You can stop coming. Only come if you think the matter bothers you again or causes any concern again. Then it enhances patient safety, because you can identify contraindications easily through the finding of the imaging study, because you can now see what you would not have otherwise seen, and then complications are prevented, so the patient is safe on the long run. Again, it also facilitates interdisciplinary communication. There's collaborative care, there's informed decision making. You can educate the patient and empower him. You can set expectations in terms of goal setting, where the patient himself or herself can also be involved, because you must pay attention to the patient's preferences in deciding what you do. Again, I want to thank you very much for your attention. That is the second presentation, and it is on the most common, easily available imaging modality and the cheapest around. Thank you. Comments, questions?
Thank you, sir.
Any question, any comment? This
Yeah,
is
thank you, sir. I don't know if my network is okay. Thank you,
Yes,
sir.
I can hear you.
Okay, yeah, he talked about the most important features which we need to look out for when it comes to assessing patients' X-ray. But I didn't see you
Okay.
mention the maybe bone fracture or the like. So is it not part of an important feature we need to look at?
Yes, of course, it is a very important feature to look at, especially when you have traumatic injuries to the chest and whatever. But you will recollect that I didn't really go into maybe specific and whatever because I was more interested in wanting to talk about the long field and things like that. The fracture of a bone can be very obvious and will not be as hidden as the other things we've tried to speak about. But it's quite important because we can have blunt chest injuries.
Thank you, sir. Understood. Thanks.
I have a question, sir.
Yes, sir. Please ask.
Yeah. I just want clarification on the pneumothorax.
Yes, sir. Okay.
So, when you are explaining the right time, so you are talking maybe the pointing of the cursor towards the edge of the chest wall. So,
Okay.
so the picture is not that clear. Maybe it's from my side, so I couldn't be able to distinguish the X-ray, the point at which the long ends between the chest
Okay.
wall and where when there is issue with pneumothorax.
Okay. Now, I use that particular film. There are other films, but because already they have helped us to mark the border of the lung and the edge of the pleura that could be seen. I wanted that so that we could actually see those red lines that they have traced and whatever. It's like the ink, the red ink itself is now lying over that edge of the pleura itself. That's probably why you couldn't see it. But what you observe is that if you look at the edge of the thoracic cage itself, if you look at the other side, you will see that the place that looks dark or black, which is the place filled with air, representing the lung field, extends towards the margin of the left side. But when you come to the right side, that dark portion did not reach the border of the thoracic cage, indicating a shift away from the margin. So that's where the air had been trapped.
Okay. Yeah.
What I will do is before the next something, I'll pick another film and show us another film of pneumothorax.
Okay.
That will not be marked, and we can just read by ourselves.
Okay.
Yes.
Thank you very much, sir. In addition, sir,
yes,
concerning the tracheal deviation, I think
yes,
concerning maybe if there is a atelectasis where it's going to deviate,
yes,
maybe
because there'll be a shift towards the collapsed region.
Yes. Okay.
The shift is usually towards the collapsed region.
Okay. But in the case of pneumothorax, that would be towards or away.
In the case of pneumothorax, the shift will be in the opposite direction to where the air is trapped, because the air that is trapped will push it in the other direction.
Okay. Okay, sir. Okay, sir.
Yes.
Thank you very much, sir.
It's a pleasure. Okay. So let's take the next or let's have a very short break, maybe 5 minutes or 10 minutes. And then we take one more lecture before the lunch break. We should still take one more presentation before lunch break, but before the presentation, maybe we just have 5 minutes or so to stand up, stretch our bodies and whatever. We are physiotherapists. Doctor, is that okay? Coordinator, sir.
Yes.
Is it okay for us to have maybe 5 minutes break, a short break, or 10 minutes short break? Then we
Yes.
take one more this thing before our lunch break.
Yes.
Yes. So it is 11:56 at my end here now. So 12:05, we start the next presentation by 12:05. Thank you.
All right, sir. Thank you, sir.
Okay. Okay. It's 12:06. It's already past our time. I hope we can start.
Yes, sir. We are ready, sir.
Okay. Thank you very much. Yes. Okay. So we are welcome back. So we move on to the third presentation. And having looked at the basic and the old school modality, X-ray, we want to look at other techniques. And this time around, we want to look at CT and MRI. Again, let's look at an overview of the computed tomography in terms of the principle by which it works and the process and how what it gathers is reconstructed to give us something meaningful. We said CT uses X-rays and computer processing to detail cross-sectional images of the body. So the machine sends X-rays at various angles and from all directions. And it gathers images. And then with a computer program, the various images are brought together to create a concise image for us. To have this done, the patient lies on a table, and the table will have to move through a circular opening in the CT scanner. And while the patient is, moving through it, beams of X-ray will rotate around the patient. And the beams will capture images from various angles. And all the images are now processed by a computer. And the computer produces a series of cross-sectional images. And these cross-sectional images are referred to as slices. So this machine varies in capacity according to the number of slices that it is capable of producing. So you have those that produce 6 slices, you have those that, provide 12 slices and so on. Now, apart from the regular scan, we have some other improved versions of the scan that are capable of providing us even with more information than the regular basic CT scan will provide. We have the high resolution CT. And this high resolution CT is capable of providing us with detailed images of the lungs. And so when we are investigating interstitial lung diseases, this type of scan becomes very useful. It can also, evaluate small airway diseases. Then we have the contrast enhanced CT. In the contrast enhanced CT, it's just like when you, in the laboratory, you do this staining procedure. You remember when we are treating physiology of blood, we'll talk about the white blood cells. And you say some are basophils, some are eosinophils, and some are neutrophils. And those names arrive from their staining properties. So the same way, various tissues in the body have staining properties in terms of how they react to certain agents. Casting our minds back to our O-level chemistry, you remember when you are doing the test between acid and base, you will say the acid will turn blue litmus red. That's the staining property. You say base will turn litmus paper blue. That's a staining property. So the same way, various tissue, especially the soft tissues in the body, have staining properties. So what is therefore done is that some contrast medium is introduced into the blood vessel as to create the typical and characteristic stain that make the image that the CT is going to pick to be sharper, to be more distinct. And so it now gives us a clearer picture than the basic CT will do. So he said this involves the injection of a contrast material to highlight blood vessels, tumors, and other structures. And it is commonly used in assessing pulmonary embolism, assessing vascular structures, assessing certain types of tumor. We also have the spiral or helical CT. Here, the scanner rotates continuously, and the patient, also moves. So instead of just the patient moving, the scanner also now rotates, and that now gives us a helical series of images. And the advantage of this is that the scanning is accomplished faster, and the three-dimensional image that is reconstructed are sharper and much better than what the basic CT will produce. So in what situation will we be interested in a CT scan rather than going for X-ray? In situations of pulmonary embolism, we will be interested in a scan because the X-ray will not pick this. And like we made mention of, contrast CT will even give us a better picture than the basic CT in this condition. There is also the computerized tomography, pulmonary angiography, which is preferred when it is pulmonary embolism in particular. This particular procedure visualizes the blood vessels in the lungs and then is capable of identifying if there is blockage in any of them. And when we as physiotherapists have a picture of the extent of embolism, it can guide us in the management of the patient in terms of the type of exercise program that we can place the patient on. We remember the FIT principle, when we are talking about exercise prescription. So we know what intensity, we know to what extent we can stress that patient and not create a secondary problem or bring about any complication of the matter. Whereas if we do not have the information that the CT can give us in this instance, okay, we know that it is embolism. It will be either of two things. Number one, we look at it, oh, there's pulmonary embolism. It's better not to exercise the patient at all. So we leave the patient untreated. And the patient continues to undergo deconditioning until, we have serious complication of the sedentary lifestyle. And then you remember that they have coined that word, sedentary death syndrome, SEDS. So we must not leave this patient uncared for. So it is only through this investigation that we have this added information. And that information can now guide us as to the magnitude of stress or exercise that we prescribe. And the patient is able to get the health benefit of physical activity or exercise and is also operating within the safe range because we are guided. Now, it is also used for cancer. And in cancer cases, it can be used to detect, and it can also be used for the staging of the cancer. So it can detect the nodules, especially when we are talking about cancer of the lungs. It can detect the nodules. It can assess the size of the tumor. It can also assess the spread, to nearby lymph nodes or even other organs in terms of metastasis. And how is this capability useful or relevant to us as physiotherapists? Now, the patient may have to undergo surgery, pulmonary resection. if it is still restricted to a particular lobe, lobectomy. But if it is scattered in one particular lung, then they may do pneumonectomy, either of the right or of the left lung. Now, depending on the extent of the spread of the cancer cells and the envisaged loss of pulmonary surface by the surgery, we can preempt to know to what extent that the gaseous exchange in that patient going to be. And we can therefore begin to walk that patient up even ahead of the surgery in order to train endurance, to train proper techniques and things like that. And of course, even postoperatively, we can then know the kind of exercise program that we can prescribe that will promote the respiratory health of that patient and maintain or rather, and avoid complication, because we can calculate the intensity of the activity that we want to prescribe. Of course, even when it is past remedy, maybe it has developed metastasis that is widespread, and as such, it's not medically advisable to proceed on any surgical intervention because the situation has reached the end stage. We can still, come up with a tailor-made physical activity or exercise program for that patient to add life to the years, so that whatever is left for that person to live, he lives in the best possible health status or physical form. Now, another situation where we use it is in interstitial lung disease. Interstitial lung disease. Sorry, I'm trying to move this thing out of my way. Yes. Okay. Now, in interstitial lung diseases, the CT can be used for evaluation of the condition, especially the high resolution type. And it can be used for diagnosis. And it can actually characterize the interstitial lung disease into phenotypes and things like that. It can reveal the pattern of fibrosis that we have in the lungs. It can identify and locate the ground glass opacities in the lungs. It can also pick several other abnormalities that the typical X-ray will not be able to pick. And when the report of all these capabilities are available to us as physiotherapists, it helps us in determining what severity of this condition can we, remediate? At what level does it become beyond help, so to say? And when physiotherapy is still able to help, what's the intensity of the exercise program that we can administer? In fixing the pulmonary rehabilitation program for this patient, what aspect of his life or performance do we lay more emphasis upon? That is, that will be our major focus. The information we derive can help us a lot in resolving all this. Of course, another condition where the CT will be indicated is in COPD, chronic obstructive pulmonary diseases, in that CT can quantify the extent of the emphysema, that's the air trapping, it can quantify the extent of the thickening of the airway wall, and by providing this information, it gives us a more detailed understanding of the disease. So we are not just saying there is emphysema, airway trapping. We know the magnitude of the trapping. We know the pathophysiology that by virtue of this, there will be hardening and thickening of the wall of the airway. But now, this modality can tell us the actual magnitude of the thickening. Now, when we now have that information, it will help us to customize our care in terms of the breathing exercises, as well as other therapeutic interventions. It could be even physical activity, it could be exercise program, and so on. We know the extent that we can go with such a patient and not overdo anything. Now, just like the X-ray, supposing the CT scan comes to me or comes to you without a report, will we be able to at least look at it and draw some inferences? Inferences that may not be complete because we are not the experts in that field, but at least that can guide our intervention. What do we do? How do we read the scan? To read the scan, we must be able to understand slices, because the slices come as axial slices, coronal slices, or sagittal slices. And we remember those planes in the body. Those were the early lectures in anatomy, planes and axes and things like that. So it is in line with those planes in the body that the slices are prepared. So we as physiotherapists need to learn how to navigate through the slices and to identify abnormalities in the different slices that may come our way. Now, one of the major features there is the density of the tissues in terms of the image. And it is the ability of the CT scan to pick the different densities that places it above the imaging ability of X-rays. even though they are all soft tissue, it is sensitive enough to be able to distinguish between them: hair, fat, soft tissue, or bone. And when there is now a problem with any of those tissues, there's a shift or a difference from the characteristic image that tissue will present. And the difference can be spotted and analyzed and be categorized in terms of what must have gone wrong. We must also be familiar with the issue of the anatomical orientation. It is as we are familiar with this that we know what deviation we can observe in the CT scan relative to the normal anatomical landmarks in the body. Usually, there are various patterns that different disorders present with. Remember, in is that physical diagnosis and clinical decision making? Yes, clinical decision making, physical diagnosis and clinical clinical reasoning, physical diagnosis and clinical reasoning. You remember, we are familiar with various models of clinical reasoning, of which the young believers, I said believers, I forgot I'm not in church, the young professionals, the model they are familiar with and they use mostly is what we call the hypothetical deductive model, which is like trying this hypothesis and dropping it, accepting an hypothesis, rejecting an hypothesis, like you do in research. It's just that in this case, not a null hypothesis that you are rejecting or accepting. It's the hypothesis of the fact that this condition should be this, which is similar to what we did in qualitative analysis in chemistry. When we have to identify a salt, you subject that salt to some known tests with known outcomes. And based on whatever outcome you have, you prune down what that salt or material might be based on its response to various things you subject it to. So the same thing here, but the older professionals, because they have seen cases, day in, day out, over years and whatever, somehow, there are some patterns that have registered in their mind, to the extent that once a patient comes to them and he narrates his story, they are able to create a pattern out of that. And immediately they know what must have gone wrong and they diagnose, even without some unnecessary investigative procedures. And they are accurate because they are familiar. So such model of clinical reasoning is referred to as pattern recognition. Pattern recognition. So the same way now, in using the CT for cardiopulmonary disorders, there are patterns. There are recognizable patterns. So you match what you are seeing with those recognizable patterns. And so you are able to identify what challenges may be present. Like in the case of pulmonary embolism, which will prevent air from getting to the alveolar, the air that gets to the alveolar, the pulmonary membrane, to diffuse into blood. Because of the embolism, the flow of blood to that particular site has been blocked by the embolus. So there will be ventilation, but there will be no perfusion. So a ventilation perfusion mismatch occurs in that place. And so eventually it affects the overall ventilation perfusion quotient. And so we have hypoxemia, whereby we do not have sufficient air in blood because there is an area where the air there, oxygen there, will not be utilized because there was no blood supply to pick the oxygen that had arrived at such membrane. Now, so in the case of lung cancer, it is able to spot the nodules that constitute the cancer cells, the cancer cells. Then it is able to spot, the mass effect, the appearance of a mass, in a body. And then it is able to spot whatever must be going on in the adjacent lymph nodes in the thoracic cage. Now, in interstitial lung diseases, viewing the CT scan, we pay attention to the presence or absence of any reticular pattern, any honeycombian, any ground glass opacity, as the presence of all these features will be indicative of the presence of interstitial lung disease. Then in condition of chronic obstructive pulmonary disease, either chronic bronchitis, emphysema, or some special type of bronchiectasis, we want to see whether there are areas of, attenuation that can be indicative of emphysema. So these are the things we look out for, and immediately we spot it, we record it, and then it guides us into the accurate diagnosis. Now, this is a sample computerized tomography of pulmonary artery. And it shows a large embolus. Look at the main pulmonary artery. Look at its width from here like this and like this. And look at, this is the pulmonary artery bifurcating into the left and the right, causing flow to continue. Now, where blood flows, look at how the vessel is distended because it is filled. But if you observe this right branch of the pulmonary artery, look at this vessel here. You can see that this vessel is not widening out. Look at this one, supplied by the same right branch that is coming. Look at how it is distended because there's a filling with blood. But here, where is it? Here, because there is an embolus, it is obstructing the flow into this vessel. So this vessel is not filled with blood. And that's why it's narrow in lumen, because it is not filled. So immediately you know that there is a blockage in that artery. Now the MRI, magnetic resonance imaging. The basics. So it uses strong magnetic field and radio frequency waves to create detailed images of internal structures. So unlike X-ray or CT, it doesn't use any ionizing radiation. So the risk of radiation is not there. So this enhances or promotes better patient safety than X-ray and CT. And how does it work? So it involves aligning hydrogen nuclei in the body with a magnetic field. And as that happens, a radio frequency pulse is sent in. And that pulse disturbs the alignment. And as the alignment is disturbed and the protons are trying to return to their original state, they emit signals. And the signals that they emit are now used to create an image. And that's the MRI image that we eventually see. Now, how is this sequenced? It is sequenced in form of weighted waves, T1 or T2. And these different waves, weights, they create different, a spectrum of contrast, such that depending on how much of the ions are displaced, intensity will differ. And so the darkness or lightness or whatever will differ. And then that will eventually form an intelligent shape that can be read and interpreted. Now, when the MRI is done, it has its own place in cardiorespiratory care by virtue of its capabilities. It is used for cardiac imaging or pulmonary imaging because it has ability to differentiate, even among various soft tissues. So MRI provides detailed images of the heart structure and function, including ventricular volumes, because the blood that flows through the heart and that fills the spaces are actually tissue. The blood is a tissue. Now, it's not just a fluid, but a tissue. Now, myocardial tissue characteristics can also be imaged. Flow can also be imaged. So we have information on each of these areas, and we can plan our treatment based on the extent to which any or each of these parameters have been altered. The same thing on the respiratory side. It can be used to assess specific conditions like congenital anomalies or pulmonary vascular issues. So when those things are assessed in terms of magnitude, we can tailor our treatment, our goals, our intervention based on the report of that image. The common indications for MRI: myocardial characterization, functional assessment, congenital heart disease, for example, because it could mirror and get image of soft tissues. Congenital anomalies like aortic stenosis, it will pick it easily. Congenital problem like ventricular septal defect, it will pick it easily. It can also be used to visualize major blood vessels, and then when they use the contrast medium with it, it even gives a better image. It can be used to assess thrombus and aneurysm because it can identify blood clots. It can, identify distortions in the wall of blood vessels. And it can also be used for soft tissue characterization. And that makes it relevant when it comes to assessment of tumors. So MRI can differentiate between benign tumor and the malignant tumor. Now, seeing that both MRI as well as CT are superior to chest X-ray, when will we want to use either? In terms of we preferring something that is higher than X-ray, the two of them qualify that they are higher. So how do we now settle the quarrel, if it is? Or how do we settle the attraction that the two of them have for us to choose? Now, when it comes to choosing between the two, we have to consider a number of things. Number one, which is utmost, is that we want to get the information that we need. And we want to be as sure as possible with whatever information. Therefore, whichever one has sufficient soft tissue resolution and will make the report to be most precise will be preferred. And we said MRI excels in distinguishing between different. And so it makes it so beneficial when we are assessing myocardial tissue or vascular structures. Another thing we will look at is radiation concern. Because in workplace and everything, there is a slogan, safety first. And we know that people have concern when it comes to the issue of safety. We know the negative effect that, radiations can have on the human body. So if it is possible to have what we want without undue exposure to radiation, then all the best. And so when we look at these two factors, they swing the pendulum to the side of MRI. So when will the pendulum swing to CT? When to use the CT? Speed. When we want the result quick. especially in a situation of emergency, when we must take decision before it is too late. The second consideration is the presence of bone structure. If there is any bone structure in the area we are assessing, CT provides better visualization of bone structure. Remember, MRI has better visualization of soft tissue. Then CT will be preferred. And so, when it comes to the issue of calcifications or bone-related pathologies, CT will be preferred over MRI. Let's now consider a kind of comparative scenario. An acute situation and then a chronic situation. Remember, we said that we can get quick result from CT compared to MRI. Therefore, when there is an acute condition, like in acute chest pain, CT can be used for quick assessment that will give us a result that we can begin to work with. And then the MRI can come in later just to verify things. So that brings us to the end of this presentation also. Questions, comments, observations? In the absence of any question, then we can have our lunch break now. Dr. Jibrin, what's the duration of the break?
I think it's 30 minutes, sir. 30 minutes, sir.
Okay. Okay.
Yes.
Okay.
So roughly
So
we will converge around 1:30 or so.
So we convert back around 1:30.
I think.
Okay.
Let's make it 2:00 now, so that it will be a standard time. Good day, sir. Good evening. Good afternoon.
Okay.
We have many things to cover.
Okay.
2:00 is more standard.
I think
now.
we have a lot to cover. Is 30 minutes not enough, please?
Okay, let's hear from some other people so that we will operate democratic something.
we need your inputs. 30 minutes is enough, right?
Please, let some other people comment. Somebody, the
2 o'clock is up.
I've suggesting 30 minutes. Somebody has said it
2
should be 1
o'clock
hour,
too.
2 o'clock. Eh?
2 o'clock is up. 2 o'clock is
2 o'clock
okay.
is okay, sir.
2 o'clock.
2 o'clock, yes, sir.
Okay.
Yeah, please.
Okay. So let's do National Assembly. The A's have it, or who are those that have it now?
2
I think from the chat, majority are going with 30 minutes from the chat.
Okay. Dr. Jibrin, the decision lies with you. Which group have it?
Okay.
2 o'clock, sir.
I think let's go to the middle ground. Let's say 45 minutes.
Okay.
Yeah.
Okay. Yes. Okay, for 1:45.
Yes.
1:45. Okay. Thank you.
Welcome back, sir. I think we can continue. Welcome back, sir. I think we can continue. Thank you.
Sorry, I didn't remember that I was muted. I was speaking and I wasn't getting a feedback. So are you able to see my screen now?
Yes.
A Word document?
Yes.
Okay, thank you. Yes. Now, I want to quickly run through this, and then we are going to also now do an exercise. Because the important thing is for us to be able to apply this thing back in the clinic. So this session is more or less like a practical session. But before that practical, and I want all of us to get ready because I want that practical session to be participatory. I want to quickly run through this. Specific usage is the title I've given to this write-up. In other words, the way we specifically use this skill of doing image studies, asking for image reports concerning our patients with cardiorespiratory disorders. Now, as an introduction here, I said by using imaging effectively, and you know, that word effectively is very important because it's not everybody that is using imaging that is using it effectively. Sometimes we use imaging like a number of Nigerian factories. They will say that factory is operating at 30% installed capacity. For example, maybe it is I remember in those days when the Ojo Automobile Assembly at Kaduna was functional. I don't know what the current state is, whether it's still functional or not, because we've not been seeing much Pojo vehicles on the road again. Anyway, as at that time, that factory, it is possible to know what is the installed capacity of that factory. For example, if it is to produce 10,000 vehicles annually, for the factory to now be working and it is producing only 3,000 in a whole 1 year because of one reason or the other, that is operating at 30% of installed capacity. So when I say that sometimes we really do not use imaging effectively, what I'm trying to imply is that there are times when imaging studies are even brought to us, and the information that we draw from it in order to utilize is just a tip of the iceberg compared with the volume of information that is actually in that document, in that report that has been brought to us. But if we use it effectively, I said cardiopulmonary physiotherapists can accomplish 3 major things aside others. Number one, they will enhance their diagnostic accuracy. And you see, when you are able to enhance your diagnostic accuracy, there's a way you can hit the nail on the head. Why is this particularly important for us in cardiorespiratory specialty? You see, it is one of the reasons I always advocate the problem-oriented approach to treatment. In orthopedic specialty, if somebody had a problem with the knee joint, he's not having full range of motion and things like that. If the therapist is not getting it right, he will continue. After some time, he may be lucky and get it right eventually. But in cardiorespiratory specialty, we don't have the luxury of time. Time is of essence to us in cardiorespiratory specialty because patients with cardiorespiratory disorders, especially the acute conditions or the critical conditions, there is a thin line between life and death. And if we don't get it immediately, a loss of time can result in a loss of life. But when we get our diagnosis to be very accurate, then we can address the problem immediately and get result promptly and save life. Number two, we can tailor our intervention. We will not be beating about the bush. And then we can monitor patient progress more effectively. And another, a related thing to that is that when we are able to monitor our patient progress and we are efficient in documentation, our documentation can contribute to evidence-based practice, because we will then be able to come up and say, we use this method, it worked. This is the extent to which it worked. And so it contributes to evidence-based practice. And how will this thing be? We want to look at, the tiny bits that will come together and constitute these three things we are talking about. Now, number one, using imaging effectively, we will be able to confirm or refine our clinical diagnosis. You see, by the time we do our physical assessment, physical examination, and all those physical diagnosis steps, there's a way an idea forms in our mind. We come up with a clinical suspicion that, oh, it must be this. This must be the problem. By the time we come out with the result of imaging study, we will be able to verify that which we suspect. Is it really the one or no? Because it's possible for us to suspect something, and eventually by the time the imaging study result comes out, we discover that, we are not on track. That's why in some tests in orthopedics, they talk about false positive. So there can be false positive results. There can also be false negative. In any way, imaging study allows us to verify, because it now gives us evidence, information that we could not, through the other steps, arrive at. Then we are able to cross-check the symptoms. And then there is diagnostic accuracy, because there is objective evidence, either to support or to refute whatever is the clinical diagnosis that had been on ground. That's one thing. Another thing is that if we use imaging study effectively, we'll be able to differentiate between conditions. We'll be able to distinguish, pathologies. Like I mentioned, during the last presentation. Imagine a patient with muscle strain. Imagine another patient with tendon tear. The physical symptoms and signs and whatever can be the same. And if we think of it to be a muscle strain, and we want to proceed with a particular line of management, we may be doing a great harm if indeed the problem is not muscle strain, but a tendon tear. With imaging study like MRI, that is very sensitive to soft tissue pathologies, it will bring it out to us clear cut that this is tendon tear and not muscle strain. So we won't fall into such an error. It can also help us to identify coexisting conditions. You see, there are times when a patient has a major problem. Coexisting with that major problem is another problem that major problem overshadows. And therefore, the patient is probably not even complaining of that lesser problem. And sometimes the lesser problem may cause more harm than the so-called major problem. But because the major problem is so obvious and distressing and disturbing immediately, that is what is paid attention to. And this so-called lesser problem that is underneath goes unnoticed and can eventually cause a lot of harm. But with imaging studies, immediately we are carrying out this, it will bring out everything, both the obvious as well as the less obvious. So we will not leave any stone unturned. We will be able to combat all the issues at the same time. Also, we are able to understand the extent of injuries or conditions. Because with the imaging study, we are able to assess the severity and extent. We are able to behold a detailed visualization because we are seeing the image. We are visualizing the problem that is so deep that our naked eyes cannot see, but in the image, we can now behold it. We can assess the involvement of some soft tissues in some other conditions that may not primarily be a soft tissue problem. These imaging reports can guide our treatment planning by tailoring our intervention towards the exact problem. It can also guide us in determining the rehabilitation goals because we can now set goals that are very smart. With them, we can monitor progress because the images themselves, when repeated over time, can actually take the place of the outcome measure, which we can use to monitor progress. And if we are not hitting it, we can adjust our treatment plans appropriately. And of course, we can integrate it to our clinical examination that we have carried out. We can collaborate with other healthcare providers, either by speaking to them or by receiving information from them. The other dimension is that with the imaging study reports, we can set realistic goals that are based on the findings of the imaging study. We want to see some example here now. Let's first of all look at examples of patients that have pulmonary conditions. Then we will look at patients that have cardiovascular problems. Then we'll look at patients that have, soft tissue challenges. That it is these other imaging studies that can bring them out. Now, the first example, a patient with chronic obstructive pulmonary disease. The imaging finding says there is emphysema or air trapping. And we got that information through the CT scan. Now, in setting the goal, we can set the goal relating to structural issues. We can set the goals relating to functional limitations in that patient. For example, in setting the goal in relation to structural issues, we can talk about improving the lung function and reducing the impact of emphysema. So when we are setting such a goal, we can look at ventilation efficiency. What outcome can assess ventilation efficiency? And we use that as our outcome measure. And we assess it over time. Another impact of emphysema is dyspnea or breathlessness. We can tailor our goal towards the breathlessness that emphysema produces. To say that breathlessness will reduce from X to Y over so time. Now, on the other hand, we can set our goal towards the functional limitation. For example, that individual may no longer be as active as possible in terms of his exercise tolerance, in terms of his endurance, in terms of physical activity participation. So we can set our goal along that line and monitor it over time, aiming at improving the exercise tolerance, improving the endurance, improving performance on the 6-minute walk test as an index of such. Now, a second example. A patient with interstitial lung disease. Actually, this is one of the cases I wanted us to use for the case-based learning. Maybe I'll just merge the two together, case-based learning. That's where we are looking at either real cases or hypothetical cases, trying to solve it as we will solve a real life problem. Now, a patient with interstitial lung disease, using high resolution CT, it reveals ground glass opacities or reticular patterns. In this case, it's saying either or. So we are going to treat the two. Now, when we talk about the ground glass opacity, it is talking about some slight opacity of the lung parenchyma that is, more opaque than the normal parenchyma, but it's not as opaque as when we have consolidation. And a good number of times, the extent of that ground glass opacity, GGO, is indicative of a number of things. Number one, it can reveal active inflammation. It's saying that there is an active inflammation going on. That's why it's not consolidation. It can, and sometimes it is reversible. So sometimes its presence can be prognostic. In other words, it gives us an assurance that there is the possibility of recovery or repair or healing because it's not yet consolidated. However, the magnitude of that opacity is also an index of the severity of the problem. You know, the magnitude or how widespread the opacity is also an index of how severe the problem is. And it can assist us in setting the goal and targeting our management. In that, because there is hope of reversal and healing, it encourages us to intensify whatever line of management is capable of resolving that inflammation. However, because it is also indicative of active inflammation, it gives us the knowledge that whatever we know can promote inflammatory process increasing must be avoided. It's just like this. Let me give us an example in terms of this issue of active inflammation. I don't know how many of us, one day you are trying to close the door of your car and it banged your finger against the doorpost, and that place is tender. You discover that a warm water that you will normally put your hand in and you won't feel anything, because of that inflammation, because of that injury, if you put that hand inside that warm water, the water is not really hot, but it's warm. If you put your hand there, you will withdraw it immediately, because according to the physiology of pain, there is what we call sensitization in that place. There's sensitization. So there is hyperalgesia. And that warmth can promote the inflammation getting worse. That's why in our thermotherapy, when somebody suffers an acute injury, we say use ice and not heat for the first 72 hours, so that the inflammatory reaction will have subsided before you introduce anything heat. The reason is that within the first 72 hours, when the inflammatory agents are still available at that site at high concentration level, if you bring heat, it will promote blood flow to the area. And because inflammatory agents like substance, P, histamine-like substance, serotonin, they are high in that place, it will promote extravasation of fluid, and it will cause the swelling to become worse. So just like we have knowledge of that now, that in such acute injury, you don't use anything hot, but rather you go for cold. So the presence of, ground glass opacity, which is indicative of active inflammation, apart from giving us the ray of hope that healing is possible, reversibility is possible, it is also a warning about some things we cannot do because it may, aggravate the inflammation. Now, let's now imagine that this scan result, we didn't have it. Is there any way we will just imagine ground glass opacity in that place? Immediately we see that, oh, there is pain or whatever. We want to use anything that can, address it without appreciating the active state of that inflammation, and it can be counterproductive. So we can see the importance of this image result here. Number one, it is diagnostic. Number two, it tells us of the state. Then how widespread it is gives us a picture of the extent. That it is ground glass opacity tells us about the stage. I mean, it tells us of the stage of the problem. That it gives the hope of reversibility, brings some element of prognosis. That it is still active, and therefore there are things we can use and there are things we cannot use, guides our intervention. That it is reversible means the amount of opacity can reduce. Therefore, monitoring the amount of that opacity can be itself an outcome measure, which means it can be monitored to know outcome. Now, can we see how just this single entity, look at the amount of inference that we can draw from that just single statement, and we have not even finished it. Hello? Can we have somebody just comment on that very briefly? How you see how much has been brought out from that simple statement? Anybody? Anybody?
Yeah, we
Just
are
a
with
free
you.
comment.
Yes,
Yes.
yes, we are with you, sir. We are with you here.
That's what I'm saying is I want somebody to just comment on, look at that simple statement, look at how much inference okay, because of our time.
My network is bad here.
Okay, sorry. Sorry for that. God will help us in Nigeria. We are still pursuing network here and there. It's okay. Is there any other person who's who got that and wants to pass any comment? Okay. So now, where I am actually driving at is that, I made a statement earlier on that a good number of times when we have this imaging study report in our hands, what we get out of it is so minimal compared to what is actually inside that thing. In fact, it's possible for a physiotherapist to come across this type of imaging study results in the case note of a patient that he is also seeing. And he just sees it, oh, ground glass opacity. And he just, brushes it aside. That, oh, this is for the people in pathology, the pathologists. This is not physiotherapy related. Are we aware that somebody can look at that statement that way? Hello? Hello?
Yes, sir.
Yes, the feed. I told us that this session, I want it to be interactive. You know, are you aware, sir, that normally speaking, it is possible for a patient to be referred for physiotherapy having interstitial lung disease, and the HRCT report is also in the case note and everything that was forwarded. And the physiotherapist goes through and he sees this statement and he's tempted to say, oh, high resolution revealing ground glass opacity, and he just set it aside.
It's very possible, sir. Majority at times we'll just look at the result and we are not really observant with some of those terminologies, opacity, and the like.
Aha. So that is the essence of we having this seminar. So that we can see that those things, they contain a lot of information for our use as physiotherapists. Now, that's about ground glass opacity. Now, let me now go to the other side. You know, it says or reticular patterns. Unlike ground glass opacity, reticular patterns are indicative of fibrosis. They are indicative of fibrosis. And they are not reversible. They are permanent and can be progressive. Therefore, while ground glass opacity gives us a ray of hope of recovery, reticular pattern tells us that the situation can only get worse.
Okay, can we say sorry, sir, can we say in cases of cancer or what?
Yes, it's possible in cancer too. But it happens also even in this interstitial lung disease. So that the condition is progressive. Now, where I want to get here now is in setting our goal for ground glass opacity now. We'll be setting a goal in terms of healing, in terms of improvement. But when it comes to reticular pattern, we will set our goal to slow down deterioration. We want to make sure that we don't allow the deterioration to happen speedily. We want to slow it down in order to prolong life and prolong healthy existence. Can you see a difference in the angle of even goal setting now?
Yes,
sir. You know, and those are the hidden things in these reports. Yes, so in terms of goal setting, it says in the dimension of structural issues, we want to slow the progression of fibrosis. Can you see that? We slow it down because it's a permanent thing, it's not reversible. So we can reverse the fibrosis and then manage the symptoms. So the goal we will set in such instance can include improving or maintaining lung volumes and reducing symptoms like cough or dyspnea. In terms of functional limitation, we want to enhance the functional capacity and quality of life. And so goals could focus on improving exercise tolerance and managing daily activities despite functional impairments. We want to simply add life to years. Now, let's now come to patients with cardiac conditions. You see, there are so many more cases we could discuss, but we don't have the luxury of time. So let's now look at patients with cardiac conditions. The first example here is a patient with heart failure. Now, we know that in heart failure, the cardiac output is lower than what is sufficient to maintain circulation around the body. So we say the heart is failing in its function. It's different from cardiac arrest, which is total cessation of heartbeat. Heart failure means performance below expectation. Now, imaging study was done. In this case, it was echocardiogram. And the echocardiogram showed that the ejection fraction, is reduced. Again, a second scenario, or there is ventricular dilatation. Looking at this, again, some physiotherapists may see this and say ejection fraction, that's not our own headache. Oh, ventricular dilatation. Oh, no, that one is for the cardiologist. Yes, the cardiologist has a role to play in this. But we must go on to look at the two issues in order to discover what is our role as physiotherapists. When we talk about ejection fraction, we are talking about what proportion of the blood that got into the left ventricle that was actually pushed out through the aorta into circulation. It's like maybe you are a government official. Government now gave you 20 million naira to address the challenges of the people in your village. And out of the 20 million that government gave you, you now issued out checks to people amounting to 5 million. That means what you pushed out is a fraction of what you received. Just like blood enters into the ventricle, and ventricle has to push out blood. Ideally, the ventricle should push out whatever blood volume was emptied into it. But this time around, it is pushing out only a fraction of it. We are going to look at the possible etiology, and then we are going to look at the consequence, because there are two dimensions to it. Something must have made the ventricle incapable of pushing out all that got into it. That's the etiology of that reduced ejection fraction. And then, since so much came into it, and it has released just a fraction of it, It means that even after the ventricular systole, there will still be much volume left in the ventricle. That's the end systolic volume, ESV. Now, as blood continues to come and it is only pushing out a fraction, what will now happen? Let's first of all look at the consequence. You discover that there will be pooling of blood in that chamber. Blood volume will continue to build up in the place. What will happen to the chamber? The chamber will become dilated, expanded. As the volume becomes expanded and the place dilated, the valve that opens between the atrium and the ventricle will be pulled apart, and the valve will become incompetent. So you are going to end up with some valvular incompetence in that place. Then, and the problem, it will establish a vicious cycle. And then there will be pooling of blood back. And then there will be problem at the lungs, because there will be a kind of backflow. So the amount of blood that will remain in the pulmonary bed will increase. And that will increase the hydrostatic pressure in the pulmonary capillaries. With the increased hydrostatic pressure at the pulmonary bed, there will be pulmonary edema, which will subsequently affect gas exchange, external respiration. Ventilation perfusion ratio will drop. Eventually, there will be hypoxemia. So you can see a catalog of events that will follow this. Therefore, let's now come back to why is it that the ventricle was not able, to push out all the blood that came in. Weakness of the myocardium. What will cause weakness of the myocardium? Most likely, myocardial infarction or reduced coronary circulation. So, in treating this condition, what do? We want to enhance cardiac output. And how can we increase cardiac output here? We now go back towards the definition of cardiac output. Remember, cardiac output is comes in, it will disrupt my internet connection. Saying my internet connection is unstable because of that call. Sorry for that interruption. Now, so cardiac output is stroke volume times heart rate. Now, what determines stroke volume? The ventricular contractility. And that is where the problem is here now. So there's not much we can do there. But on the second side of the equation, heart rate, there is what we can do. So you remember acute responses to exercise in terms of heart rate. When somebody engages in exercise, heart rate increases. So we place the person on activity, exercise. Exercise will increase the heart rate. So each time the ventricle pushes out blood, it will still push out the volume it is capable of pushing out. But because heart rate has increased, the number of times that it is now pushing out that amount has increased. Let's look at a situation. I'm just giving some mathematical model now. I am not being precise. The heart was beating at a rate of 60 per minute before. Now, it is only able to push out, let's say, 400 mils of blood. That means it will push out 2.4 liters per minute. Now, meanwhile, cardiac output is supposed to be 5. But it's performing at 2.4. Now, I now place this person on physical activity exercise. And that raises the heart rate to 75 per minute. At 400 mils per beat, 400 times 75. That becomes 3 liters. That's an improvement in cardiac output from 2.4 to 3. 3 is closer to 5 than 2.4. So we can see. And we physiotherapists are the exercise experts. Meanwhile, somebody had looked at this and saw ejection fraction. Oh, that's for cardiologists. The cardiologist is not the exercise expert that is going to address this. So we set our goals. Now look at the other side of the O, ventricular dilatation. Remember that when I was talking about the reduction in ejection fraction, I told us of what will be the consequence, that there will be pooling of blood in the ventricle and it will get dilated. That's the ventricular dilatation that is mentioned here. Now, we set our goals either related to the structural issues or to functional limitations. So we want to address the cardiac output and improve exercise capacity. So we want to set our goals to increase tolerance to physical activity, to improve, symptoms like fatigue or shortness of breath. And in terms of functional limitations, we want to enhance functional independence. Because such a person, because of the symptoms of fatigue and whatever, would rather want to lazily sit down and say, look, I feel tired. I don't seem to have energy to do anything. Meanwhile, if he continues that way, he will continue to get deconditioned because of the sedentary lifestyle he is trying to adopt. So we are the ones that can reverse that sedentariness by prescribing activity, setting goals to increase, daily task performance. let's look at the second example in terms of people with cardiac challenges. This case is a case of myocardial infarction, not the acute phase, but the post-acute phase. Reason being that in the acute phase, physical stress will be contraindicated. Now, an imaging study was ordered, and the appropriate study was MRI. Remember that when we are talking about MRI, we say it is very sensitive to peak myocardial scarring. Scar talks about deadness, scar tissue, when the skin dies and it forms a scar. So the scarring is also the same thing as or infarcted areas, myocardial infarction. You know, that's what has formed the scar on the cardiac musculature. So MRI shows that. Now, imagine a patient that is just manifesting symptoms and comes to you. There's no way that with your eyes you can see the scar on the heart. So you wouldn't even know that there are scars on the heart. And you might mistakenly go and do something that can make the scar to get worse. But now, the MRI imaging study has brought what is in the dark into the light for you. You can now see it. So you now know what you can prescribe and what you cannot prescribe. And the magnitude of the scar can tell you about the extent of the infarction. And that can guide the extent to which you can stress the patient. Now, that means you have to put this patient through a cardiac rehabilitation program. But in putting him through the cardiac rehabilitation program, you are going to, fix the intensity of the exercise. Remember, when we are fixing the intensity of exercise for cardiac conditions, we either set a percentage of the maximum heart rate or a percentage of the heart rate reserve. Percentage of maximum heart rate or percentage of heart rate reserve. Percentage of maximum heart rate can be calculated from Laven's equation now that talks about 220 minus age. So if somebody is 60 years old, for example, you simply deduct 60 from 220, you have 160. That means that person, the expected maximum heart rate for that person is 160. But you don't want to exercise the patient to that maximum rate. So if the amount of scarring is minimal, you can say, okay, I will exercise the patient to 70% of the maximum heart rate. 70% of 160, that will be 112 beats per minute. So if the resting heart rate of that person is 70 or 72, it means that you can subject him to activity and his heart rate is increasing. But immediately the heart rate reaches 112, you must stop because you should not exercise the person beyond that. But if the scarring is much, it will not be safe for you to exercise that person to anything close to 70% of his maximal heart rate. Then you can adopt maybe 55% of the maximal heart rate. 55% of 160 will be 88. Let's say approximately 90. Which means that with a resting heart rate of 70, as you begin to exercise that patient, immediately he exercises to the point where his heart rate reaches 88 to 90, you must stop. So you can see here now where the outcome of the MRI study has been useful in guiding the intensity of your exercise, which is your intervention. So you can see that it has guided your intervention. It has guided your treatment plan. The other one is if you want to exercise him at a percentage of heart rate reserve. Heart rate reserve is maximal heart rate minus resting heart rate. Like we calculated the maximal heart rate of that person to be 160 and the resting heart rate is 70. Then it means that the heart rate reserve is 160 minus 70, which is 90. So you now use a percentage of that 90. You can say, okay, exercise him up to 50% of his heart rate reserve. 50% of his heart rate reserve is 45. So 45 plus 70, that's 115. It means that from resting heart rate of 70, as the person continues to exercise and his heart rate reaches 115, you must stop. But if the magnitude of scarring is much, you may not even be able to exercise him up to 50% of his heart rate reserve. Probably you go 20% of his heart rate reserve. 20% of his heart rate reserve is 18. You add 18 to 70 and you have 88. So this is how this imaging study can guide what you have to do. Now, let's move on to patient with structural heart or vascular condition. The first example is aortic stenosis. Aortic stenosis is where there is a narrowing in the aorta. Usually it is common around the arch of the aorta, shortly after it emerges from the heart, and it crosses over the pulmonary arteries. That's where it often gets stenosed. So, and when there is stenosis there, it means that the heart will have to push forcefully to push blood through it. And so that places a lot of load and work on the heart. And because of that, it's just like when you work your muscle, you put your muscle on weight training. What happens to the muscle? The muscle builds up. And that's what happened to the muscle of the ventricle. And so you can see left ventricular hypertrophy. So that's what happens. Oh, sorry, I was talking about aortic stenosis. I was describing coarctation of the aorta as aortic stenosis. Aortic stenosis is stenosis of the aortic valve. The narrowing at the aorta is coarctation of the aorta. Sorry, that's coarctation of the aorta. So, in both is the same increased workload on the left ventricle. So left ventricular hypertrophy, happens. And before you know what is happening, as the musculature of the heart, continues to work forcefully and builds up muscle, remember it is itself supplied by the coronary arteries. The coronary arteries, by virtue of its size, what it will now supply to the musculature will be deficient. It won't be sufficient for the bulk of muscle that has built up there. So the risk of myocardial ischemia resulting into myocardial infarction is very high in such a patient. So that's one of the things you want to prevent as you plan your management. So you set your goal to improve cardiac function. And so you want to enhance cardiac output, and you want to reduce chest pain or dizziness. The next one is pulmonary embolism. And usually, that is from ventilation perfusion and scan, with CT. It says it shows area of reduced perfusion due to embolism. You remember that image that we saw where the right pulmonary artery is not properly filled because there's an embolus blocking the flow there. So the area is not well perfused. So gaseous exchange in the part that is supplied by that vessel will be compromised. So blood oxygenation will be reduced. And so risk of hypoxemia and therefore what will be our goal? It is to improve oxygenation. How will oxygenation be improved? In that person, initially it may require administration of oxygen to boost the partial pressure of oxygen inside the alveoli so that the amount that can diffuse across, even at the sites where diffusion can be active, will be much and compensate for the area that is not participating in gaseous exchange. Now, that's to just show us how these imaging studies, the findings, can temper what we do diagnostically, intervention-wise, goal-setting-wise, monitoring-wise, outcome-wise. Now, the aspect that follows here now, I don't think I should belabor that, in that we are quite familiar with goal setting and the fact that our goals must be smart and so on and so forth, whatever. So now, general approach to goal setting. When we now want to set our goals, we must assess the imaging findings. What are the specific structural and functional abnormalities that the imaging study revealed? Because it must guide the goal that we are setting. Then we set goals that are measurable, SMART. That the goal we set relates to the structural or functional abnormality, is the specific aspect of the SMART. That the goal is measurable is the M of SMART. And of course, though it is measurable, we must make sure that it is not beyond accomplishment of the patient. So it must be achievable. So you set the goal a bit at a time, and then you can progress. Remember the principle of progression. Then we said goals must be SMART, which means that after the A, we have R. And R means it is relevant. So, to be relevant, we incorporate the patient's preference and limitations. So when the preference of the patient or the limitation of the patient has been incorporated into the goal, then the goal becomes relevant to the patient. So we say you should align the goals with the patient's functional needs, preferences, and any physical limitations so that the goals are realistic and motivating. And then, of course, the T of SMART, whereby it must be time-bound, and that becomes the issue of monitoring over time. So you use follow-up imaging and regular assessment to track the progress. And as you track the progress, if necessary, you may need to adjust the goal as the patient progresses. So, summarily, we say that by tailoring goals to the specific findings from imaging studies, we can create more targeted and effective treatment plans. We can enhance outcomes. We can support patients in achieving their rehabilitation objectives. Now, the other part is how to choose appropriate treatment techniques and intervention. I'm not going to belabor that because while I was explaining the issue of goal setting, I've already alluded to some of such. In that, while I was talking, for example, about goal setting, I spoke about the exercise program. I spoke about the intensity of the exercise program, being such that the patient is not over-labored. And I used 2 dimensions in which you can use to, set the intensity, maximum heart rate reserve, and things like that. And then whether you choose aerobic exercises or, activities of daily living, depending on the patient's capability and tolerance. So these are the issues involved in talking about, appropriate treatment technique. And the intervention could be in form of exercise. It could be in form of manual therapy. And it may be in form of modalities. In exercises, we have quite a number. We have walking, we have jogging, we have treadmill exercise, we have bicycle ergometry, we have a step bench, depending on age, because we know that step bench will not be appropriate for elderly persons, but rather for younger and more agile people. We have various forms of aerobics. Then, in terms of manual therapy, especially if the problem is respiratory, the various chest physiotherapy in terms of vibration, percussion, shaking, clapping, and in some instances, apart from that, we can also use devices. For example, we have some devices like flutter, we have a cappella, we have the high frequency chest wall oscillator and things like that. So we have quite a number of devices that can also be used apart from the hands. Then when we talk about modalities, well, all those appliances are also modalities. But apart from that, sometimes even some electrotherapeutic modalities may be relevant and useful. So depending on whatever is the symptom that the patient is presenting with, I will stop there and allow us to ask questions so that we can now have a kind of better interaction. And then we will round up at 4. Because somehow, I have to be in church this evening. So as we close by 4, I will just prepare to go to church. So thank you very much for your patience and for your attention. Questions, comments, observations? Hello, questions? Okay, somebody has sent in a question. At what point do we begin exercises after a diagnosis of myocardial infarction? Okay. Yes. The point of commencement depends on the physician's assessment, and it's usually when the various cardiovascular indices have become stable. Is the stability of the vital signs and the cardiovascular status of the patient becomes stable. Stable. In other words, not fulminant. Okay, somebody is saying, can we get a copy of this Word document? Definitely. In fact, I will remember to send the thing. Even the presentation for last week, I remember that Dr. Jibrin sent a message to me that people were asking for it. I will send everything. The presentation for last week, the PowerPoint presentation for today, as well as the Word document. Everything shall be sent to the organizers. Any other question? Dr. Jibrin, over to you. It's like
okay, thank you so much, sir,
it's
for
like we are
the
not having questions.
in-depth presentation, and we thank everyone for participating. Wishing to see you some other time. Thank you so much.
Yeah, we thank God.
Yes.
So bye, everyone. Love you all. Hope to see you some other time. Thank you for your attention. Thank you for your patience.
Thank you, sir.
Yeah, thank you. Oh, somebody has just sent a question now. He's asking if, apart from maximal heart rate, if we could use the oxygen saturation. The oxygen saturation is not an index of stress. It is just an index of how much oxygen is available in blood. And the honest truth concerning that is that even though it is that much saturated, what the tissue extract from it is very minimal. That's why even the fetus inside the mother's womb survives on venous blood. So the so-called venous blood is still so rich in oxygen that the fetus survives in the womb on venous blood. So it's not really much of an index for our activity, but rather it is an index of the efficiency of gas exchange in the lungs. It's an index of the efficiency of gas exchange, not an index of efficiency of activity performance. Okay. Yes, I can see one new message. Do we use the same protocol in excising patients with coronary heart disease? Yes. It is the same protocol in that it is the cardiac rehabilitation program or protocol that we implement for them. The only thing is that the exercise for each patient is customized for that patient in terms of the various components of fits, frequency, intensity, type, and time. So those are the attributes that differ from one patient to the other. The protocol and the components of the cardiac rehabilitation program is essentially the same. But the frequency is not necessarily the same between one patient and the other. The intensity is not the same. The type is not necessarily the same. And the time or duration is not necessarily the same for any two patients. Those are the things that differ. The FIT principle, F-I-T-T. Somebody says, in acute setting, while therapy is going on and the physiotherapy becomes tachycardic, increase RR and reduce BP, would this be a marker to query pulmonary embolism or just to carry on in case where no CT has been actioned? Okay, the patient becomes tachycardic, and reduce BP. Not really. In such an instance, that is talking about the heart rate and not the oxygen level. Rather, when you are treating a patient in the acute setting, what you should focus on more is your pulse oximetry, which may give you an idea about saturation or desaturation. The tachycardia in terms of heart rate is just a reflection of a deconditioned state. It means that the heart rate response to activity is exaggerated. Question is about pulmonary embolism. Do we still exercise patients, and what are the precautions to be taken to avoid dislodgement of the embolus? Now, the embolus is already a detached element. It is the thrombus that we don't want to dislodge. Embolus is already a dislodged thrombus. What of patients in ICU with pulmonary edema? Yes, patients in the ICU with pulmonary edema, they may be there for other reasons. If they have pulmonary edema, exercise will be done with caution and under proper monitoring. And if desaturation is observed, then the exercise is stopped. That is the place of pulse oximeter and the monitoring, the ICU monitor.
So what about patients with CCF?
Patients with
CCF, chronic cardiac failure.
Chronic cardiac
failure.
Okay, yes. In heart failure, what is happening is that the strength of the myocardium to push out blood is reduced. So what will have to be done for that patient still is graded exercise. But you exercise the patient within his capability, and then you can slowly graduate the exercise intensity. To not exercise the patient at all is to promote deterioration.
Well understood. Thank you, sir.
Yes, sir.
So I want to ask, for example, patients with cardiopulmonary conditions, is it mandatory that we need to, you mentioned some of the variables that we need to take note, like the cardiac outputs and the likes that we are talking about when we are discussing the one aspect. So is it mandatory that we always watch all these variables, we stay close to it in order to avoid fatigue or
especially for patients that are in the ICU. That's why the monitor is close by. As they are being treated, we should watch the monitor closely. And one thing we must particularly watch consistently is the SpO2, oxygen saturation. We don't allow the oxygen saturation to fall below a certain level, especially for patients in the ICU. This problem of desaturation, it must be avoided. Reason being that the brain needs a lot of oxygen. Patients in ICU with pulmonary edema. Yes, when patients are in the ICU, and there is a pulmonary edema, all they will do is to give oxygen. They will give oxygen to boost the partial pressure of oxygen in the inspired air and await the edema to resolve. At the same time, they are tackling whatever must have triggered the edema. But while the edema persists, oxygen therapy is compulsory.
All right. Okay, sir. Okay, let me give an example. Maybe a patient with advanced condition, maybe multiple condition. For example, hemorrhagic patient with hypertensive heart disease in the ICU, and the SpO2 is around, let me say, is fluctuating around 95, 96.
Yeah.
Can we still go ahead and even with the cardiac electromonitors that are there,
Yeah.
can we still go ahead and give a moderate or design a particular exercise for that patient? Because some of our physiotherapists, what they do is that once they see so many of these things, they will just reschedule. Is it appropriate?
I'm afraid, yes. Even the SpO2 being 95 is still not worrisome. SpO2 of 95 is not worrisome. It is if it falls below that it becomes worrisome. And then more so, such patients will be in the ICU normally. And when patients are in the ICU, there is not much intensity of activity that you put them through that is a threat to that. Rather, it is other things that produce the desaturation rather than the exercise. So it is those other things that often cause the desaturation that we must beware of. Especially, sometimes a patient is intubated, and in trying to carry out our procedure, the tube is displaced and things like that. So such causes are more common than the activity being the one causing the desaturation, because the intensity of the activity is not that much on the ICU bed.
All right, thank you, sir. Because what
Pleasure.
I do most is when I get to the ICU,
Yes.
most of the patients that maybe they have hemorrhagic CVD and maybe some other cardiopulmonary underlying conditions.
Yes.
I try to streamline my management, maybe PM like maximum of 30 reps in 1 week. So it will just be 5, 5, 5. Maybe for the lower lane, the PM, the passive mobilization, I don't go beyond. But when I see that the vitals are getting better, I intensify maybe to 10 reps until that patient is being, maybe the condition changes for good, and from there we carry on.
Yes,
Well, I
that's
discovered
actually
that
the
most
definition of the vitals becoming stable. That stability is the key.
Yes, yes. Thank you, sir.
Yes. Can we give passive instead of active with ICU? Yes. In fact, a good number of times in the ICU, there is more of passive, movement than active exercises, because a good number of times the patients in the ICU, they are in a state of altered consciousness. And so they might not even be able to follow your instruction as to be able to carry out active exercises until their situation improves and the GCS rises above certain level. And there are some patients with respiratory conditions that may not get to the target SpO2 of 94%, and these are considered as normal. No, once it is falling below 95, it won't be considered as normal. What about COPD patient? What's the question about the COPD patient?
So you said 94 is low. So I'm asking, what about COPD patients? It's not like a good range for them. Was they really get up to 9900?
Yes, the fact that there is COPD simply means that there's obstruction. Obstruction is in terms of flow. Saturation is about exchange of gases at the pulmonary membrane. So when we talk about the COPD thing, the parameters that are affected are mainly in terms of FEV1, FVC, and FEV1, FVC ratio, not the saturation. Saturation is about gas exchange at the pulmonary membrane. Obstruction is about flow in the airway.
Sir, please, I want to get something. So if that obstruction now in the airway now, is it not going to cause more retention of CO2? And how can O2 come inside when CO2 is more inside than the O2?
Yes. Now, in COPD, you see, you discover that what is causing the COPD, the CO2, whatever, is because the symptom is actually marked during the expiratory phase and not the inspiratory phase. In terms of inspiration, they hardly have any obstruction during the inspiratory phase. And the reason is this: inspiration is an active process. It is driven by muscular force, which is the diaphragm, whereby the diaphragm contracts and there is increased dimension of the thoracic cage in the 3 dimensions: antero-posterior diameter, lateral diameter, and vertical diameter, resulting in increased volume. And because of the increased volume, pressure drops. And so air goes in from the atmosphere. So it is driven by the bellow effect of the diaphragm, primarily. It is when the respiratory minute volume exceeds certain value. That's when the external intercostals will come in to assist inspiration. But expiration is a passive process. It normally happens as a result of recoil of structures that were stretched during inspiration. So there is not much force behind it. So when there is now obstruction, it is more marked during the expiratory phase that has little force behind it. And that's why, in order to empty the air, they now make efforts during expiration to push it out. And that's what causes the wheezing sound. Now, when you now look at the oxygen saturation thing, you discover that even the partial pressure of expired air. When you look at the oxygen saturation in the expired air, it's still much. That's why in some conditions even, we administer what we call the rebreathing bag. Rebreathing bag. It is because even in the expired air, if you breathe it in again, there is still so much oxygen in it that can keep you. So for COPD, it's not much of the issue of desaturation. It must be very severe, where in condition like status asthmaticus, where the breathing is extremely labored, and there's so much period of apnea and things like that. So that's when we have okay. So once again, thank you very much. Let me begin to prepare for church.
Thank you, sir. Thank you, sir.
Thank you very much. So, Dr. Jibrin.
Thank you so much, sir.
Oh, thank you.
Really appreciate more added knowledge. So we're looking forward to the
Amen.
next one. Oh. I'm looking forward to the next
so
one.
much.
Oh.
Thank you very much, sir.
No problem. Thank you.
Hafiz, sir. Thank you very much, sir.
Hafiz, how are you?
I'm fine, sir, Daddy.
You ran away without telling me.
I'm so sorry, sir.
It is well.
Yes, sir.
Well done,
You are blessed mightily.
Amen,
well
sir.
done, sir.
Thank you very much, sir.
Yeah, thank you very much.
Yes, sir. Thank you very much, sir.
Thank
Thank you
God.
for the lesson, sir.
Thank you for the
Thank God.
lectures. I'm very excited.
Emmanuel, you
Yes,
are
sir.
there.
Yes, sir.
I can see your face.
We
Quite
enjoy
some
this
time.
session, sir.
We bless God.
Yes, sir. Thank you very much, sir.
This is an evening of Emmanuel. So, Emmanuel Chukwuneke, how are you?
I'm fine, sir.
You are blessed.
Thank you, sir.
Yeah.
I joined all the way from Phoenix, sir.
Amen. Okay, bye. Yeah.